My name is Elizabeth Fitzgerald, and I am a pediatric emergency medicine doctor at UNC. My other hat that I wear here at UNC is I work in global health in Malawi, trying to help build and develop a pediatric program in Lilongwe, which is the capital of Malawi. KCH is the Central Region's referral hospital, and it's also considered a local hospital to Lilongwe. If you were to go to KCH, you would see some of my favorite people. The emergency zone where I work is pretty big in size. It has probably about, I would say, 40 beds. And each of those beds has several children on it. The moms are sitting on the beds or next to the beds with the children. It's fairly crowded. There's a resuscitation bay in the front where the sickest kids go, but for the most part they all just stay in the emergency zone until they get well enough to go into the other wards. We've initiated some programs that we're trying to develop more of an infrastructure to train young Malawian physicians. We're trying to help augment clinical capacity there through training and development, and we're trying to do quality improvement projects for the hospital. We started a database. So if you can imagine, there is almost no information. Like I was saying before, there are so many deaths that go unaccounted for. There's so little information about patients that come to the hospital that it's hard for us to know where and how to improve care. The clinicians are so overburdened and the resources are so inadequate that oftentimes they can't even document basic information. So with the age of the patient, their past medical history, their vital signs, just basic information that we as clinicians use both in the moment to diagnose and treat, and then retrospectively to look at what we could have done better, where could we have intervened earlier, what did we miss. And that's quality improvement, and it's an essential component of healthcare in the United States that we would like to bring to Malawi. So in order to do that, we need baseline information. Amazing, and we were able to hire a team of 7 people who are working around the clock 24/7, and they are looking at the patients who come into the hospital, getting their demographic and their initial clinical information, and then following them throughout the stay and looking at their outcomes. And it sounds so basic, but this information will be the cornerstone for us to then look back and make quality improvement and hopefully continue to decrease mortality at KCH. For me, it's bearing witness. So it is being a voice for these kids. Some of these kids die and we don't know whether they were boys or girls. We don't know how old they were. We don't know their names because it's such a chaotic environment that they come to us either already dead or dying, and we don't even have basic information about them. So in a situation like that, sometimes I feel helpless as a physician, and so I feel like what I can do is I can tell their stories to people and hopefully generate some empathy and some resources so that we can change their stories. I think I do what I do because I am every mother that is sitting next to their child, and because they deserve the same care that my children get here. And because I am lucky enough to have this opportunity and this education and this access to resources like at UNC, and I feel like it's a moral obligation to bring these things to that environment so that those mothers have the same feeling of safety and hope for their kids that we do here.